So this is a bit of a plan for the evening. Monica came up with the name. I'm just going to blame her for that. So we're going to very quickly talk about why it's like a good thing to know. And then for about 15 minutes, we'll talk about how you would approach patients with a breast lump. For 15 minutes, then we'll do a little bit on breast cancer, 10 minutes on management plans. And I've got like 2 MCQs I've made up. And stop me at any point if you have any questions, and feel free to go and get like tea, coffee, whatever, anything you want. So why is it important, do you guys think? You can put it in the chat or you can speak out loud.
There is a high incidence. And
yeah, good.
There's lots of mortality.
Yeah, perfect. Do you know how common? So you're talking about breast cancer, yeah?
Yeah.
Yeah. Do you know how common breast cancer is? Just roughly.
Like, second most common.
Oh, that's really impressive. I wouldn't have known that. So yeah, I found that out when I looked it up. So yeah, it's like the second most common. In terms of why I'm going to teach you it, it also comes up quite a lot in exams. And it's important to recognize cancer when you see it. And also a lot of GP consultations, especially if you're with a female GP, I've often found like people finding a lump, or you at least see like a couple in a week. So this is some stuff I got from it's Cancer Research UK. So yeah, it's like very common. But what I didn't realize is that a lot of it's a disease of older women generally, but it does occur in younger women, which is why we also look out for it. And the changes in like breast cancer treatment have been huge, and we've made like huge progress over the last couple of years, or last like 20 years and stuff. So, how would you approach a patient complaining of a breast lump? Like, what questions would you ask? Anything, literally anything. So you can put it in the chat, or you can tell me.
How long they've had it for when they noticed it?
Yeah, good. Who's that?
Aishwarya.
Aishwarya, perfect. So how long they've had it for and when they noticed it. And why is that important, Aishwarya?
Because if you know, if it's like a sudden onset, then, or if they only recently noticed it, then it could kind of help differentiate the different diagnoses it could be.
Perfect. Yeah. So if someone noticed it and it's sort of come up overnight, that's very different to someone who says, oh, I've had this for like 30 years and it hasn't changed, isn't it? Good. Anything else? Think of. If it fluctuates with menstruation, that's really good. Why? Why is that important? What does that sort of point you towards? Yeah, more benign. Perfect. And that's the same with like a lot of women have just like a bit of pain with menstruation, and if it sort of goes up and down, then you're much less concerned about it. So far we've said like the timing, when they noticed it, if it's changed, if it fluctuates with menstruation. Anything else that you guys could think of?
Painful or painless?
Yeah, good. Why are you asking that?
Because if it's more cancerous, it's painless now.
Yeah, good. So the thing which I didn't realize until like last year is that cancer can cause pain. But you're right, if it's a painless lump, and especially if it's like hard, that makes you more nervous. Whereas if it's painful, you might more think of like, well, tell me, what would you guys think of if something's like painful and inflamed? Be more likely to be like an infection or something like that. Yeah, good. Any discharge from like the nipple. Let me see what else I've written. I've just written history, which was very vague. What else would you do for this patient? So you've taken a really comprehensive history. So if they've got any pain, you've asked Socrates. You've asked about any other conditions that they've got. You've asked about family history. What would you do next after your history? Literally, like, don't overthink it.
Examination?
Yeah, perfect. Yeah, so you'd examine the breast. and then you do some investigations potentially, depending on what you find. So this is just like a little way I always say my investigations, just because it means that basically in an OSCE or locus or whatever, I know you guys don't do locus anymore, but for the mock locus, if you go straight for CT, it looks a bit bad because it looks like you don't know any other investigations, whereas you do, and you might be right, this patient might need a CT, but I always start with like what I can do at the bedside. So in this case, I guess there's not that much, but yeah, you could, if you needed bloods and then imaging and then everything else. Does that make sense? Happy? Sound. I'll carry on. So, have you guys heard of a triple assessment? This was supposed to like pop up. I was supposed to ask you what it was. But does anyone know when we'd refer someone for triple assessment? So, I guess you guys might not have been in. But what a good thing if you get a chance to do, if you're on breast surgery, is you can go and they run these like, these are the 2-week wait clinics. So these are the 3 components of a triple assessment. So you get a clinical examination and it's generally by a breast surgeon. And then they grade it from like, I think it's 1 to 5, 5 being, I'm, pretty sure this is cancer, and 1 being, this is just a normal breast, I can't feel anything. And then you do some kind of imaging, and then you sometimes take a biopsy. So what kind of imaging would you do you guys think?
Mammogram.
Yeah, good. So why are mammograms good?
Isn't it like a more sophisticated ultrasound for the breast?
Yeah, so they're like, if you've ever seen them done, they look terribly painful. I'm too young to have had a mammogram, but they look pretty sore. So they're basically big things that squash the breast, and then you shine an X-ray through it. But it doesn't look like a normal X-ray. It is all sort of strange looking. I can't really interpret them. So they're good in older women because the breast is less dense as people get older. But in younger women, what's another method that we could use to image the breast? So not an X-ray, but what's a good one? It's cheap, no radiation, say, quick, ultrasound. Yeah, perfect. So in younger women, we use an ultrasound. And also that shows really well like cysts because they're fluid filled. And then you take like a sample if there was any like concern, if there was anything you could see. Does that make sense? So if you're worried someone has a breast lump, then you need to refer them for like triple assessment, which will take place within 2 weeks. So what could a breast lump be? Literally like any differentials of a breast lump.
Fibroadenoma being the most common one.
Yeah, good. And what is a fibroadenoma? Like, what would you feel on clinical examination?
It's a guess, but they wouldn't have the same features as cancer, so maybe they're well bordered.
Good.
They're less firm.
Yeah, perfect. So I love, it's really good that you guess, because most things, at least, I don't know if I'm supposed to say this, but most things I reckon you can like guess. So you're right, it doesn't feel like cancer. So it'd be, well, they call it like circumscribed, but yeah, it just means like bordered. Would it move about or stay in the same position, do you think?
Move about.
Yeah, good. So they're called like breast mice, which is a bit weird because they move so much. So the woman might come in complaining of it, and then you might not be able to find it, but it is still there. So yeah, they're really common in women under 30. You don't really need to do anything about them. Anything else that it might be? Obviously, someone's mentioned like breast cancer, so that's your one that you'd be concerned about. Any other causes of breast lumps? Someone mentioned like hormonal fluctuations. What would that likely be? So have you heard of like you can get cysts in the breast, just like you can get cysts anywhere else? Any other thing? Any other benign thing? Okay, I'll put some up. You can tell me if you've heard of them. Oh, okay. So if someone asks me, what could it be? It's always good to structure an answer. So you can say, it could be a benign cause or it could be a malignant cause. So some benign common causes would be fibroadenoma, fibroadenosis, which always used to really confuse me. So fibroadenosis is like lumpy, painful breasts, which is in older women generally, or not old, like people in their 40s. Something called mammary duct ectasia, which is basically where the duct gets a bit big, or like a little papilloma, so just hyperplasia rather than like a cancer. And then something called fat necrosis, which anyone who's done much past medicine on breast will know about because they always ask about it. So I've never seen it. I don't think it's very common, but typically the question stent is like a obese 50-year-old woman. I remember one of them's like got hit by a cricket ball and has come in complaining of a painful lump in her breast. But these people, if someone is 50 and comes in complaining of like a lump in their breast and it feels quite hard, you need to refer them to the 2-week wait clinic to the triple assessment because it might be something nasty. Does that make sense? So even if you think it's fat necrosis, you need to refer them. And then the malignant causes breast. Oh, and a breast abscess as well. And a malignant causes breast cancer. So does anyone know how a breast abscess would present? They're not super common, but it's a good thing to know because it's the same as any abscess pretty much. So how might a breast abscess present? What might it look like? So, everyone happy with what an abscess is, first of all? It's okay if you aren't. So, effectively, I'll explain it in case anyone's about. So, it's just like a collection of pus and gunk in a space. So, you probably feel pretty unwell with an abscess. So, you'd have like a swinging fever, they call it. So, it goes up and down as your body responds to this abscess. You'd feel pretty grotty. It'd be very tender. You know, like everyone's had like a spot or something. Imagine that, but effectively a massive spot. It'd be very tender. You'd feel rubbish. When you looked at it, it'd be all red and sore. And when you tried to touch it, the patient probably would not be very keen to let you. So these, yeah, aren't super common. They tend to occur if in anyone, in women who've been breastfeeding and then have got mastitis, so like inflamed breast where like the milk's clogged up the ducts and it's gotten a bit of an infection. So yeah, it's not super common, but if you see it, it's important. Okay. So, oh, these were two things I wanted to mention. So does anyone know what this is in the context of breast cancer? So it looks a bit like eczema on the nipple. So if you haven't heard of it, it's called Paget's disease of the nipple. And it effectively is like a sign of breast cancer. So if you see anyone with eczema around their nipple, they need to be referred to the 2-week wait clinic. Because it's one of those like occult signs that you might not necessarily recognize. And this isn't obviously a real picture. This is called, so it looks a bit like mastitis would look. So the breast is like red and angry. Does anyone know how this is related to cancer? You can put it in the chat if you want. Okay, so this is like inflammatory breast cancer. So I think what happens is the like lymphatic ducts get blocked by the cancer, and so you get like a red, swollen, inflamed breast. So if you see a breast like this in anyone who isn't breastfeeding, then that's like a really cause for concern, and they need to be seen in the 2-week wait clinic. So it's not just breast lumps that you would send; it would be any of these changes as well. And I think also in like women over 50, it's like inverted nipples and stuff like that. But I don't really know that, to be honest. But yeah, it's mainly breast lumps and these two things which are important to account for. So in terms of breast anatomy, I didn't know this you've got these lobules, and you've got ducts, effectively, which are like the important parts of the breast, and then you've just got like fatty tissue around. So you don't tend to get cancerous fatty tissue. So the cancer has to either occur really in the lobules or the ducts. So does anyone know how we can classify breast cancer?
TNM, like most cancers.
Yeah, good. Anything else you can do? So you're right. I didn't even write that on the slide, but yeah, you're right. You should classify it by TNM. So there's some extra stuff that you do for breast cancer. Just like I reckon there's probably extra stuff you do for like all different cancers. But this is something they might. I think they probably just ask you what's like the most common type of breast cancer. So like with lung cancer, you know, we classify it by like TNM, but we'd also say, well, there's small cell and non-small cell. And non-small cell is X, Y, and Z. With breast cancer, we say we can also classify it by the type of tissue, if it's spread out of the duct or not, and then if it's special type or not. So, does anyone know what the most common type of breast cancer is? You just don't really need to know. Well, I guess you need to know the most common. I think that was it though. So, invasive ductal carcinoma, which is confusingly also called no special type, and then everything else is special type. So invasive lobular carcinoma is like the second most common one. And then you get ductal carcinoma in situ and lobular carcinoma in situ. So those make up like the vast majority of breast cancer cases. And then there's also some of these like extra ones that you don't really need to know, but it's just good to know that other cancers can present in the breast. But like a lymphoma will be treated by a hematologist, not a breast surgeon, or not a breast like oncologist. Does that make sense? Everyone fairly happy? Okay, we're speeding through. So, does anyone know how you might manage breast cancer? Literally any answers is fine.
Conservative medication and surgical.
Oh, perfect. It's like you've seen my slides, Glenn. So, yeah, conservative, medical, which you could like split into hormonal or biological, surgical, and then you often give like radiotherapy. So, a good thing to, or what I guess I find helpful is to structure my answers. Everything almost you can do something conservative for, and then you can do something medical and or surgical and like something else. So, if who would you consider conservative treatment in, do you think?
Vulnerable patients who are like maybe extremely elderly and can't tolerate any treatment like a surgery or chemotherapy.
Yeah, perfect. Yeah. So if a patient is, you know, very elderly or has got lots of comorbidities that, yeah, you'd really struggle to do the surgery with, then you can just manage them either conservatively with like analgesia and support at home and stuff like that, or you can sometimes give them a bit of hormonal treatment that will just keep the cancer sort of slow it down a bit. Yeah, perfect. And then most other patients get a combination of, well, I guess no, quite a few people are just managed like with surgery and radiotherapy, especially people who cancer is found in the small stages. But some people need to be managed medically as well. So, surgical management. Do you know what you would think about if you're like, what type of surgery you might do, what you would like consider?
How many nodes you've got to take out? If it's spread it quite a bit, it won't just be the breast. You might have to go into the axilla deep.
Perfect. Good. So, if if you do your clinical examination and you can palpate lymph nodes, that's not great. So, if you can palpate the lymph nodes, then you're going to have to do an auxiliary node clearance. So basically, just take the nodes out with the primary surgery. If you can't palpate the lymph nodes, then you can do an ultrasound. if the ultrasound shows up the lymph nodes as like, they call them hot, effectively like they look a bit suspicious, then you do something called a sentinel node biopsy, which is you take like the closest node to the cancer, the one that goes, if you've ever seen breast surgery when they like inject the dye and then it goes blue, and then they like have the beeper thing which finds the radioisotopes. It's quite interesting. And they like put it along the armpit until they find the right lymph node. So if it is, yes, you can do a sentinel node biopsy, or if it's negative, if the ultrasound doesn't show anything, then you don't need to do any like biopsies there. In terms of what surgeries you can have, does anyone know? There's 2 different surgeries.
Like breast saving or something along that line, so you don't have to cut the whole thing out.
Yeah, good. And what's the like opposite of that, or the other one?
Oh, mastectomy, the whole.
Yeah, perfect. So you can either do a mastectomy, or you can do a wide local excision, or some people call it a lumpectomy. Basically, you just take the lump out, or you take the whole breast away. So why would you take the whole breast away? You can put it in the chat if you want. Like, what factors would make you think, oh, we need to take the whole breast? Literally, don't think too much about it. So if it's, go on.
In your family and like as a prophylaxis.
Yeah, so you can do, some people have prophylactic double mastectomies. And then those can be like nipple sparing, or they can take the nipple away. So yeah, you might do it then, or you might do it if someone's got a large cancer in a small breast, or if the cancer is so large that you would struggle to like keep the breast. And then if the tumor is in the middle of the breast, you're more likely to need to do a mastectomy than if it's on the side, because if you think about like, most women want the same cosmetic result or a similar cosmetic result, because obviously it's a very difficult thing for people's body image and stuff. And if you're able to keep the shape of the breast without taking away too much tissue, then you can do a wide local excision. But if not, it's best to do a mastectomy, and then you offer them reconstruction. What else I've written down about reasons to offer a mastectomy rather than a wide local excision? If it's a multifocal tumor, so basically if it's like a tumor which you think is seeded throughout the breast, then that's when you'd consider doing mastectomy as well. So even if you had a wide local excision, I'll put up what you consider. Hang on a minute. So why is it not working? So in terms of surgical management, you consider the lymph nodes, where the lesion is, how big the breast is, how big the tumor is, if it's multifocal or just one lesion, and if they need radiotherapy. So if you do a wide local excision, most people need radiotherapy afterwards because it reduces the recurrence by 2/3, I think. If you do a mastectomy, people are less likely to need radiotherapy, but would still need it if they're like T3, T4, or if they got lots of positive lymph nodes. Does that make sense? Everyone fairly happy? Sound? Okay. So in terms of the medical management, does anyone know anything we give for breast cancer? I'll be impressed if you do, because I didn't until I learned it.
Estrogen receptor like antagonist. I might be confusing them with another drug, but is it trans? It's something like that.
So you're so close. So it's tamoxifen. So that's hang on a minute. So I'll do that bit in a minute, but I'll write them out. So selective estrogen receptor modulators, which is stuff like tamoxifen, or aromatase inhibitors, which you give postmenopausal women. And then you can also give this, which blocks Herceptin. So what you do when you find a tumor is you take it out and you test for like the chemical markers on it. So if it's receptive to estrogen, then you want to block the estrogen. If it's got like HER2 receptors, they're called, then you want to block HER2, which is why you use trastuzumab, which is Herceptin. So why would you use chemotherapy? if we've got these great these things that can block, they're like targeted cancer therapies. So why do we ever use chemotherapy anymore?
Sometimes those cancer cells are clever, so they mutate and the receptors change, so it's no longer doesn't work.
Perfect. Yeah. So sometimes the cancers change, so they don't respond to the therapy that they once responded to. And another reason that we use chemotherapy is sometimes breast cancers don't have these markers, so they're not responsive to estrogen and they're not responsive to HER2. So that's what's called, I don't know if you guys have heard of it, triple negative breast cancer. So that's much more difficult to treat. And then you can do chemotherapy before or after. I'm not going to go into the reasons why you do it like before or after, but neoadjuvant shrinks the tumor before you operate. So that could help you save some of the breast. And adjuvant will be after. So if you found out that the cancer was a bit more extensive than you previously thought, then you can give people chemotherapy after. Does that make sense? Okay, so I've got a couple of questions and then that's it. So, okay, everyone can put in the chat what they think they might do for this one, if you want. So, you can all read, I'm not going to read it out. What do you guys reckon? C? So Sam said C. Glenn's also said C. Anyone else? Perfect. Yeah, so you're right, it's C. Oh, someone, okay, perfect. Everyone said C. So in theory, breast cancer is pretty rare in women under 30. But if someone presents with breast cancer symptoms, you're still well within your rights to refer them. And the fact, what are the breast cancers like? What makes you think of my breast cancer? Something to do with the clinical examination. So it's like tethered and fixed. So that's quite concerning in like any lump. Okay, next one. Oh, why is it not moving? Okay, I'll let you read it. Yeah, perfect. I'm fine. Okay, so what would everyone do? A/B. So this, you're right, is not quite as like clear cut. So the fact that it's a firm round lump, round things tend to be not too bad in my understanding, because it's not like irregular and hard. So this lady, you refer under the 2-week rule on account of she's in the right demographic to get breast cancer, and it's a firm lump. And also, a lot of people you see in the clinic, like in the 2-week wait clinic, don't necessarily have breast cancer. So it's all right to go and check, like you're well within your rights to go and check. So does anyone have any questions? No? Perfect. Thank you guys for bearing with me. I appreciate it. It's very difficult at the moment. You've all got a lot on, so hats off to you. I wouldn't want to be doing my final for sure. So yeah, just look after yourselves. If you've got any questions, let me know. Yeah, I think that's everything.
Thanks, Cora. That was fab. I've just put a link in the chat feedback. If you would be able to fill that out, that would be amazing.